Mariya doctor, missing blue sclera in the rush to repair, overlooked entity in corneal tear and its implications.
Hello, good morning everyone. Thank you for giving me this opportunity to present today. I'm Mariya doctor from LV Prasad Eye Institute, and I'll be presenting on the topic of missing blue in the rush to repair, an overlooked entity in corneal tear and its implications. So as we know, patients with connective tissue disorders have multisystemic involvement, manifestation ranging from involvement of the skeletal system, the cardiovascular system, the respiratory system, blood vessels, and the eye, which will be our main focus of discussion today. Ocular involvement mainly has a characteristic feature of blue sclera, which appears due to the weakness in the collagen, which gives the uveal hue of the underlying uveal tissue. Also, due to the collagen weakness, there is keratoglobus commonly seen in these patients, along with brittle cornea. We know that the outcome of open globe injury is extremely poor in patients with connective tissue disorders. Hence, with this background, we decided to do a study to look at the outcomes of open globe injury in patients having blue sclera, and also to look at the time of recognition of blue sclera, if it had any implication in protecting the other eye. This was a retrospective study done at LV Prasad Eye Institute, and patients were included from December 2000 to 2024. It was an EMR database search where a keyword of blue sclera was used, and the inclusion include minimum follow-up of 3 months. Total of 17 patients were included, and patients mainly included had an age group of around 12 years, that is mainly ranging in the pediatric and adolescents presentation. There was no difference in the gender predisposition or the laterality of presentation. However, high parental consanguinity was noted, suggesting autosomal recessive inheritance pattern in these patients. Trivial trauma and spontaneous perforation accounted for 50% of trauma in these patients, whereas actual accidental trauma accounted for the remaining 50%. Another important thing to note is that initial diagnosis of brittle cornea or blue sclera was only noted in 60%, whereas it was missed in 40% of the patients. The most common systemic involvement included hyperextensible joints, cardiac anomaly. However, there was a limitation here because echocardiography was not performed in all patients due to the monetary constraints, and also hearing loss or sensory neural hearing deafness was also seen in these patients. Again, consistent with the finding that these patients have an underlying collagen tissue disorder which needs a systemic workup. Most common clinical presentation included a linear corneal tear, and complex tear was present in 65% patients. Surgical complications included constant leak and cheese wiring, which was noted during the repair, and tissue adhesive was needed in 8 patients. So out of the 15 patients who underwent corneal tear repair, 8 needed tissue adhesive application along with the corneal tear repair, whereas 2 patients also needed a penetrating keratoplasty because the tear was inamenable to just a normal corneal tear repair. Further, 8 patients also needed repeat corneal interventions. Another interesting finding that we noted was adherent leukoma was commonly seen, that is up to 88%, and it had a high prevalence even post-repair. Even when on table, the anterior chamber would appear to be formed. However, post-operatively, these patients would develop an adherent leukoma. Visual acuity outcome, there was no difference between the first visit and the last visit, again indicating that these patients, once they have trauma, the visual outcome or the recovery is extremely guarded, the prognosis is guarded in these patients, and probably prevention has a better role. And also, if the patients in which the blue sclera was identified early and the treatment was planned accordingly, had a much better visual acuity as compared to the ones in which the diagnosis was delayed. Number of surgeries had a worse association with the final visual outcome. That is, in patients who underwent repeated or multiple surgical intervention had a worser outcome, and hence in these patients it's best to just provide them tectonic stability. Also, early diagnosis had a weak positive correlation in protecting the other eye and preventing the worsening of vision in the other eye. However, the p-value was not statistically significant. But clinically, I think we can take it because looking at the clinical picture, we do know that if one eye is damaged and if we educate the patients, we can definitely protect them for the other eye. Hence, to conclude, blue sclera is a critical diagnostic clue but is often missed or under-recognized in our emergency setting and the trauma care providers. Young age, consanguinity, trivial trauma and blue sclera should raise a suspicion of underlying connective tissue disorder, and it must be investigated accordingly. And certain things even during surgical intervention should be kept in mind, such as these patients would have a difficult repair and would need an addition of a tissue adhesive during intraoperative surgery. Thank you.
So, were these the old patients of the institute who came with trauma, or these were just the fresh patients who just came to the trauma OPD?
So it was a retrospective study. Whoever presented with the history of trauma, like they came with presentation of ocular trauma.
No. What I am saying is, like, if these patients were already visiting the institute before the trauma,
No.
then you would have the records.
No,
of
they were after they visited. Like this is the first presentation when they visited. Before that, we had no record of them.
So when you did the surgery must have been done within few hours of presentation.
Yes.
So instead of a full workup, which you are saying is needed for systemic evaluation, can a few good history points give you a clue rather than, because if you are looking for doing surgery in an emergency setting, sometimes at odd hours,
Yes.
you may not get a full systemic workup within
So-
that time.
Correct.
And maybe missed a few good history points which you would take as a emergency resident
Right.
would probably point to these things and maybe aid in your diagnosis.
Yes, sir. Thank you for that point. So actually for the surgical intervention, we just perform some basic investigation and take them up for surgery. This is when we did a retrospective analysis, we realized that these histories were actually missed, even though our residents are aware about it. But I think looking at the ocular trauma, they get so focused on that they forget to take these history. So this is an entity, even blue sclera is usually missed. So because of the laceration or the bleeding or something. So I think the other eye, examining
that's what
the
I'm
other eye
saying.
and
Actually,
history is
like
extremely important.
if you do a good history and examination of the other eye, you should be able to pick up blue sclera.
Exactly, yes. So probably
So-
educating.
So basically a good clinical examination and history is what is needed rather than going for a full systemic workup in an emergency setting.
Yeah, we don't do a systemic workup in an emergency setting. This is for follow-up, that these were the things that we noted and these were the associations
These were the
found.
things which we've missed.
No, echocardiography and the cardiovascular abnormalities which were later on found on the investigations.
My question is, like you said, because the blue sclera was missed, we missed collagen tissue disorders. So what exactly did you do to diagnose collagen tissue disorders? Like echocardiography for sure is not the way to diagnose collagen tissue disorders.
No, so
So
first
what
visit,
test have you done? One minute.
Sure.
I have 3 questions. Secondly, tissue adhesive being used along with surgery. I thought it was a surgical requirement rather than something to do with collagen tissue disorder. It's the case-to-case basis. And the third one is adherent leukoma. I don't think it is in any way related with the collagen tissue disorder. Adherent leukoma occurs when during the surgery a part of the iris is a part of the traumatic process. It gets adherent to the corneal scar. So how is collagen tissue disorder associated with it? And how do you prevent this? That also is not very clear in your presentation. Because you said it can be prevented. If we diagnose a blue sclera, we can prevent it. But they have come in an emergency setting. How will you prevent it?
okay. Thank you, ma'am, for the questions. So for the first, so f-
Yeah.
yeah. So for the first thing, on the first day when the patient, after doing the emergency repair, on the first day, these were the points that were actually taken in complete history evaluation, and then by taking the complete history, that's how we made a diagnosis. Because in the emergency sitting, our main goal was to take the patient for a laceration repair. Second question, I don't really remember.
How exactly did you come to, because it's a retrospective analysis. Agreed, you missed it the first time. After that, you concluded that the patient had collagen tissue disorder. So what exactly is a clinching diagnosis? How did you diagnose it as a collagen tissue disorder?
Asking him about the hyperextensible joints, ask him if he has, looking even the family history, any other, so
No.
even
How
on,
can you, I mean,
so blue sclera, so on, so
it's
these
okay.
patients,
Okay, thank you. Thank you.
So do you
Thank you.
recommend that all patients coming to trauma OPD or in emergency should be evaluated for systemic disorders pre-surgery?
no sir, that's not what I said.